Okay, Assalamualaikum. So today's our lecture is hemostatic agents during dentistry. This will be our fourth lecture of our pharmacology lectures. So start it with the name of Almighty. Okay. The arrest of the bleeding by the physiological properties of vasoconstriction and coagulation or virocervical bleeding. Basically, the question. Basically, what are we doing is we are arresting it with the help of arresting bleeding with the help of vasoconstriction or with the help of coagulation or by surgical means. Okay, means of promoting the wound hemostasis. There are following methods which promote the wound hemostasis, which include physical method, electrical method, suture ligation, pressure dressing, and chemicals. Okay, what about the physical method? So first method is physical method by using the fabric sponge, place the pressure on the bleeding vessel. Okay, we can do this thing. Then we can by placing the hemostat. Okay, then the second thing is the both the method cause placement of blood. Okay, small vessels require pressure of only about 20 to 30 seconds, and large vessels around 5 to 10 minutes. This can come in an exam as an MCQ. You should know that. Okay, electrical method we can use is electrocorticoid basically. Okay, this is the most commonly and most frequently used. Okay, by the use of the heat to cause the cut end of the vessel to close. This is basically known as thermal coagulation or electrocorticoid. Okay, these are the surgical hemostats by the help of which we do hemostat. Okay, and this is the electrocorticoid you can see. Okay, uh, and this is the, as I told you, placement of the sponge. This is a physical method. Okay, we place it in the socket or across the vessel which is very much bleeding. Okay, then we have suture ligation. If a vessel is cut, each end of the cut vessel is grabbed with the hemostat. The surgeon then ties a non-resortable suture around the vessel. Okay, then we have pressure dressing. Placement of pressure dressings around the wound that creates pressure in the small vessel that were cut, promoting the coagulation. Okay, then we have chemicals as well. Okay, vasoconstriction substances, basically placement of epinephrine in the wound. It serves as a vasoconstrictive most effectively when placed in surgical wound at least 7 minutes before the surgery begins. Okay, absorbable gelatin sponge, most commonly used. It is basically most commonly used and it's least expensive. Okay, example is gel foam basically. Okay, it is placed in the socket and it is held in the position with figure of 8 suture. Okay, then we have oxidized regenerate cellulose. Example includes Surgicel. Okay, it promotes coagulation better than the gelatin sponge, which is a good thing because it is curated and be placed under the pressure. Okay, topical thrombin. What is topical thrombin? Basically, it is liquid preparation saturated on the gelatin sponge and inserted onto the socket and is secured in place with the figure of 8 suture. So basically, gauze bag is placed over the site. Thrombin converts immunogen to the fibrin enzymatically and it forms the blood. This is a very important MCQ and it comes with exam as well. Basically, it's a thrombin which converts fibrinogen to fibrin enzymatically, which forms the lot. Okay. Then there is a collagen. It promotes the platelet aggregation and thereby accelerates blood coagulation. This is very important if you know. Okay, what dental management of the patients with hemostatic problems? So this is a one topic. Problems encountered are impaired platelet function, vascular defects, impaired coagulation. Impaired platelet function includes thrombocytopenia. The count is below 10,000 cells per ml. Radiotherapy, leukemia, and connective tissue disease. Okay, platelets transfusion necessary if count is below 50,000 before a dental procedure like extraction or a peritoneal surgery. If due to immune destruction of platelets like in the idiopathic thrombocytopenic purpura, then the corticosteroid administration is given along with the splenectomy and platelet infusion. Okay, PRP, platelet rich plasma, and PRP, platelet rich concentrate. Okay, and drug therapy. Okay, drug therapy includes aspirin, NSAIDs, sodium valproate, phenytoin. If a patient are carried on such patients, suture and pack the socket to minimize the risk of post-accident hemorrhage. Okay, vascular defects, which include defects that cause impairment of immune cells. Okay, which include basically vitamin C deficiency as well. Okay, long-term corticosteroid therapy. Vitamin C is basically essential for the collagen synthesis. This is a very much important thing. You should know that. And it comes in exams as well. It's a very important MCQ. Okay, there is an increased capillary fragility which can cause bleeding problems after surgery. Long-term corticosteroid therapy can cause both the thrombocytopenia and inadequate constriction of the small vessels after surgery. This is a very much important thing. Both these factors led to the hemorrhagic problems, okay, controlled by the pressure, suturing, and packing, okay. Moving on. So we have impaired coagulation. Basically, inherited defect is also plays a very much role in impaired coagulation. The most common one is the hemophilia. It is sex-linked affect only males, and it is reduced due to the reduced factor VIII activity. This is a very much important thing. You should know that, and it comes in exam as well. Bleeding onto the into the muscle joint follows the injuries, hemarthrosis, and post-extraction bleeding starts 1 to 4 hours after trauma and lasts 3 to 40 days and is not controlled by pressure. So you should know that. Prolonged activated partial, so basically what are typical findings in hemophilic patients? Prolonged activated partial thromboplastin time, normal for thrombin time, normal bleeding time, fresh plasma voided, cryoprecipitate and dried freeze fracture can be given. Problems encountered are surgical and post-operative hemorrhage, hazards of anesthesia and IM muscular injection, risk of hepatitis, aggravation of bleeding by the gust of and anxiety. Okay. What is the management? Management is basically you take history, you do radiograph, hemostatic screening is done, basically APTT test is performed, PT test is performed, platelet count is performed. Okay, factor VIII assay is done, fibrinogen estimation is done. Okay, surgery carried out on Thursday and Friday since bleeding is most likely on the day of operation or um, 4 days post-operative. All the surgeries with the factor VIII cover. Factor VIII effective for 12 hours only, also should be repeated twice daily post-operatively. Aminocaptoic acid can be given, largely replaced by the tranexamic acid 1 gram daily orally, 4 times daily and starting 24 hours post-operatively. Okay. Hazards of anesthesia injection, lingual tissues in the lower molar region should be left undisturbed since trauma may open veins into which bleeding and pack. Inferior dental and posterior superior blocks or injection in the floor of mouth and IMB avoided. Infiltrating peripheral aspirin, phenyl, butazone, and other inflammatory agent avoided. Okay. So now there is a Christmas disease. What is this basically deficiency? It is due to the deficiency of factor 9, which is also known as the Christmas factor. Okay. Deficiency of factor 9 leads to the Christmas disease. Okay. And half-life is greater than the factor 8. So given at a longer intervals, dental management is basically the same. Von Willebrand disease, it is inherited disorder, prolonged bleeding time, and deficiency of factor 8. Okay, so deficiency of factor 8 led to the von Willebrand disease, and deficiency of factor 9 led to the Christmas disease. So you should know that. And prolonged bleeding time and deficiency of factor 8, replacement therapy necessary. Okay, anticoagulant therapy. So, what is anticoagulant? Basically, you give heparin. Anticoagulant effect lasts up to 4 to 6 hours. If emergency extraction is needed, it should be carried out when the effect is minimal. A patient on the continuous therapy should be given IV protamine sulfate at a dose of 1 mg per 100 units of heparin. Okay. Monitoring of patient for some time is essential. Oral anticoagulants. Those regimes need to be altered for a surgical procedure like infection. Minor surgeries continuing therapy with monitoring of proximate time along with suturing of the hemostatic material in the socket. Okay. Before major surgeries, stop therapy. 5 mg vitamin K given pre-op or 2.5 mg given for 2 days pre-op. Plasma infusion and anti-fibrinolytic agents are also given as well. Absorbable gelatin sponge. These small sterile surgical sponges are prepared from specially treated purified gelatin solution. Each sponge is a hemostatic device that is capable of absorbing and holding within the meshes many times. It fits in whole blood. These sponges can be implanted during the surgery, okay, and will be completely absorbed within 4 to 6 weeks. What is MCH? Basically, microfibrillar collagen or hemostat. It is a topical agent composed of resorbable microfibrillar collagen. Okay, it attracts platelets and allows for the formation of blood clots when it comes to contact with blood. Unlike the hemostatic clamp, no mechanical action is involved. Okay, the surgeon presses the MCH against the bleeding side, and the collagen attracts and helps with the clotting process to eventually stop bleeding. Okay, so this is basically your collagen sponge. Okay. Oxidized regenerative cellulose are sterile absorbent native fabrics prepared by the control of regenerative cellulose. The fabric is white, pale yellow cast and has a faint caramel-like aroma. It is strong and can be sutured. Okay. in surgical procedure to assist in control of capillary venous and small arterial hemorrhage when ligation or other conventional methods of the control impractical or ineffective. Okay, stops bleeding in 2 to 3 minutes. Okay, this is an ORC, basically oxide regenerative cellulose. So with this, our today's lecture ends. So I hope it was understandable to you guys. So thank you for watching it. Allah Hafiz.